Good morning, everyone. It's a real pleasure to be here, and thank you to the ORF team for organizing this two-day session and also this particular panel, which looks at reimagining the global health architecture. We're joined by a great panel today, Dr. Shambhavi Nayak, Head of Research at Takshashila Institute, Dr. Sanjay Patanshetty, who is the Head of Department of Global Health, Prasanna School of Public Health, Dr. Sonalde Desai, Professor in National Council for Applied Economic Research, Dr. Chandrakant Leheria, and Dr. Gagandeep Kang, who is a professor at the Wellcome Trust Research Lab, Division of Gastrointestinal Sciences at the Christian Medical College. Thank you for being on this panel. I think we don't have a very long panel today. We have about 45 minutes, but really I think this is just the start of a conversation. I don't think anyone really needs to be reminded of how COVID really disrupted our lives, kept us on our toes in different ways. Every time we thought we are at a stable level and we can get back to some sort of normal life, there was a different type of crisis in front of us that we've had to respond to. But I think most importantly, it really laid bare that there are healthcare inequities that are felt by the global north and the global south. There is an uneven distribution of health, there are social and economic risks, and that there are gaps in global health governance. The G20 has also recognized and prioritized this issue. In some ways, because the pandemic was so real and felt by everyone, but really bringing on this idea of how do we look at global health architecture, and the Indonesian presidency has actually made it one of its key pillars, and that's in a sense to be expected. Today, I think it's really important for us to think about how do we carry forth this conversation, this prioritization that has happened at a global level, but really also thinking about moving from a framing around pandemic preparedness and response to thinking about what is a strong and resilient health system. And I would say that goes beyond really just what the health architecture is, to also thinking about allied spaces and allied sectors to ensure that there is good health, there's dignity, there's livelihoods, and that there is equity in at least in terms of access and in terms of how communities are able to live. So just maybe with that, we can start and just have a sort of short opening remarks from the panel. Maybe I can start with you, Dr. Kang, just to sort of reflect on maybe three broad themes. One, the importance of global architectures, global opportunities, areas like the G20, and what is possible when we think about health and the G20 and other political platforms of international cooperation. Second, thinking about equity and what is it that is really required to ensure that equity. And maybe third, thinking about resilience. So just with that broad themes, Dr. Kang, over to you.
Sure. I hope you can hear me. I think the one thing that we can say is that everybody learned something during the pandemic. We may all have learned very different things, but there was a fair amount of learning. And if we think towards the future, if we don't make use of that learning, then we are condemned to repeat the events of the past. So what were my key learnings in the context that Sachi has framed? I think the first one is about having the right people with the right skills and the right training. India has a huge advantage in our population, in our graduate educational system. And if we can develop the right kinds of feeders, I think there is a lot we can do to supply ourselves and the world with well-trained people in a variety of different areas related to health. We already provide the doctors and nurses, but we could also provide the epidemiologists, the laboratory scientists, a whole lot of other people that are really needed in order to be able to respond to the delivery of health during pandemics, but also outside of pandemics. So people is one thing. The second thing is we've also been pretty good about products. But have you noticed nobody wants to use our products? So we made vaccines that are restricted to our country. We made lots of diagnostics that we heard wonderful things about, but nobody else wants to use them. The problem really, I think, is regulation and our regulatory standards matching the rest of the world. If we can really focus on those areas, on making sure that when we make a product, we deliver it with a quality that people can accept sight unseen and don't need to inspect and have reports written from the FDA and others, that would be really useful. And the only way we can do that is if government and industry decide to work together to say that we need to have a focus on quality. Quality, I think, almost always leads to equity. If you have sufficiency of a product that is of high enough quality, you will be able. What's the enemy of equity? The enemy of equity is scarcity. You don't have enough resource to divide among all the people who need it, so people who have more access get it more easily. So I would stop there and hand off to other panelists.
Thank you, Dr. Kang. Dr. Desai, if we can come to you, please, just maybe speak to the three themes, and I think we'd really appreciate it if you could speak also to the question of resilience.
Thank you, Sachi. Let me start with the notion of resilience. It seems to me that our success was in utilizing systems that were in place. Where systems were in place, we could use them. Where they were not in place, we couldn't. So the interesting example is actually providing the social safety net and benefits. Okay? We were able to send money to women whose Jantan accounts were registered. We were able to send money to people who were registered under PM Kisan, okay? But we were not very easily able to send ration or money to migrant laborers who were not registered under anything. Okay? Now, unfortunately, it ended up being a bit of a mismatch. Okay, in that the pandemic effects were much larger in urban poor areas than in rural areas, which is where all of our safety nets had historically been focused. So I think thinking in terms over a longer period to build sort of systems would be one area to think about. I really do feel pretty strongly about building better social safety net registries, because it's very clear that there will be disasters. There will be flood and there will be earthquake and there will be a variety of things that will occur, which is when we will need to get safety net and social support out to people. Unfortunately, there is also the issue of privacy, and how do we maintain privacy while building sort of better social registries is something that we really need to think about in terms of a voluntary system of registration. Okay? And it has to be area based, because I think that our historical mindset, which has been around sort of providing a safety net to the scheduled caste, scheduled tribe, historical accidents of birth doesn't seem to work as much as sort of accidents of life. And so we may need to build sort of registries which cover the whole populations of certain areas. Okay, that's one part of it. Second thing is what else worked? What worked was actually our local health delivery systems, our ANMs, ASHA workers, and people who were on the ground. Okay? So thinking about developing a better structure about providing services on the ground, and perhaps in a multi-purpose way, because there may be other events may be very different from a pandemic. Okay? So somewhat of a convergence across different ministries and creating a local pool of ground level personnel who can be trained in emergency via things like Zoom and digital training to be repurposed would be something else I would like to think about. Thank you.
Thank you, Dr. Desai. Dr. Leheria, maybe over to you, and if I can request that you speak also to the themes of of equity.
Thank you very much. And good morning. So let me flip the question from what worked to what did not work. The reason is very simple that if we keep talking about what worked, we will not learn much. So we learn maximum from when we start thinking in terms of what did not work. So in this context of inequity, there is a 2013 book by Angus Deaton, The Great Escape: Health, Wealth, and the Origin of Inequality. Angus Deaton was awarded Nobel Prize in 2015. So in this book, one of the key argument he's making about health, he says that much of the economic growth of high income countries or developed countries happened because they started interventions after two past pandemics. One which started in 1817 that resulted in a great sanitary movement, and then 1918 to 1920 pandemic also resulted in medical and other healthcare advances. So Angus Deaton argued that the economic growth of European nations or many of the high-income countries is attributable to what they did after the pandemic challenge they faced during those periods. Now we have 100 years later another pandemic of the similar or possibly greater magnitude. So we should definitely act, and all countries should act to address those inequities. Now, one of the difference between previous two pandemics and now this pandemic is that time they did not have G20. Now there is G20, and that's an opportunity. And since G20 focuses upon economic growth, and that's why I want to talk about why it is an opportunity for G20 as nations, but also for India's presidency, that attention should be given on improving health services. In this context, I would like to flag that the health, though G20 core focus is economic growth or economy, trade, etc., but health discourse in G20 is not completely new. As early as in German presidency in 2017, they had set up a health working group which had a focus on health systems, undernutrition, other aspects. Then Argentine presidency, they started focusing upon antimicrobial resistance, health system strengthening, childhood obesity. Japanese presidency focused upon universal health coverage. Then UK and Italian presidency, there was a lot of attention on vaccines, therapeutics, and diagnostics, and equitable access. But if we look at the last 6 years, there are two overarching messages. That there is not much of the continuity in what every country started on health services. So they talked about obesity, antimicrobial resistance, but every country, when they assume presidency, they actually switched. That's one overarching message, and that's the learning for Indian presidency, that there had to be something which should be done, which will be more long-lasting. I'll talk about more in little more detail. The second lessons from the last 6 years or so to presidency is that even in the last 3 years, UK, Italian, and now Indonesian presidency, there has been a lot of focus, like not only focus, but health system resilience, vaccines, therapeutics, and diagnostic access. But if we look around, we know that it's so inequitable. And that is the challenge, and those are the learnings which we should be carrying. More specifically, we are talking about in the context of COVID-19 pandemic, that post-pandemic, what we are going to do. But then even the post-pandemic discourse is not going to be completely new. G20 in the last year, in January 2021, had set up a high-level independent panel on framing the global commons for pandemic preparedness and response. So, and there was a report in June. There was a global health summit. So all of those dialogues have happened. Alongside the discourses, there is also international dialogue going on, whether the existing international health regulation, which are mandated from WHO, IHR 2005, and the new discourse on formulation of global pandemic treaty. Now, what would happen, and not within the discourse of this discussion, but what it highlights that existing mechanism or governance framework for responding to pandemic at the global level are insufficient. So either IHR need to be revised, or a new pandemic treaty should be there, and that's where G20 could pay attention to. I'll summarize that what can be done in this backdrop, the context I have set up. The key is that like as India will assume presidency, there is a need for thinking, and Mr. Amitabh Kant was also discussing that this is 1 year presidency, but we need to think of a long term. The system need to be created, set up that this should go a longer term perspective. There should be continuity on what is being done. More specifically from India's context, I believe that considering India as a pharmacy of the world in the terms of vaccine therapeutics, Dr. Kang highlighted one issue of regulation in that, and I believe that that's the one area where we should be. It's not India specific, but there are 20 countries, but then it's an opportunity that dialogue in the context of this pandemic should be carried forward. Final point, so on some of these aspects that, and I would restrict to one final point, maybe I'll come back to on other aspect again. Let's make it two. That one is G20. G20 is a broader perspective, it's not health focused. So this is an opportunity that pandemic happens because of multi-sectoral actions, climate change, deforestation, antimicrobial resistance, or indiscriminate use of antibiotics, urbanization. So it's an opportunity to interlink all of those. And final and most important thing is that we need to, global community need to focus upon or move away from international to a global approach. And let me elaborate in 30 seconds what international.
Dr. Leria, sorry.
The final point. So international focuses upon that every country keep thinking of their own without going into global community. Like they think their own priority. Of course, countries would think of their own priority, but G20 is 60% of world population. It need to also think of remaining 40% world population. Thank you very much.
Thank you, Dr. Leria, and we can come back to that. I think that's a great point that you made. Dr. Nayak, if we can come to you, and I think Dr. Leria has brought that now issue to the fore, the G20s. And if you have, we'd love to hear your thoughts also on how, how does India approach the G20, and when it comes especially to the question of global health architecture?
Right. Thank you. First of all, I would like to thank ORF for inviting me, and particularly Dr. Sameesaran. And I also want to take a minute to thank Janvi and Shruti for arranging my trip. It was a bit of a hassle, so thank you guys for bringing me here. I want to start off by first saying that health is at an intersection of political and human realities that we cannot walk away from. And if it comes to consensus building within G20 in these turbulent times, then health is a really good pivot for us to use going forward, because there's no growth or prosperity without healthy people. So let's use that as a pivot as we go into this presidency. Use that as a catalyst. It should be relatively easier for us to build consensus there. With that, I think there should be two things that we should focus on. One is goal setting for the world, as well as capacity building. And I'm looking at three very broad areas where we could do this: primary health, disease monitoring, and nutrition. And in that backdrop, I think what India can do, we can leverage where we are geographically located, because a number of emerging diseases in the past few years have been in and around our geography. Look at disease surveillance there. We can champion our successes, maybe manufacturing or vaccines. How we can improve that obviously is a big question going forward as well. But champion our successes where we can, and use the G20 to augment our existing capacity for improved health outcomes for India as well as for the remaining countries in the G20. And particularly also our neighborhood countries which are not in the G20, but our health also depends on their health at the same time. So with this, I have three key recommendations that I think the G20 might be able to work, the presidency might be able to look at. One is a G20-led distributed network of stockpiles of essential medical supplies. This should mitigate against three things. One, the shock to supply chains that we saw during the COVID-19 outbreak. Two, the inequality in purchase power parity that we saw, where because there was a supply reduction, we saw people who could actually buy at higher prices bidding for those, and therefore a lot of countries which required products were not getting access because they just did not have the money. And third is protectionist policies, which may come into play again if there is a stark resource deprivation. The second recommendation is to have an emerging pathogen or disease monitoring system, again distributed within the G20s, particularly with a focus on our geography, because again emerging diseases seem to have taken a liking to our geography, and not just restrict them to human but also to plant and animal pathogens, because we can't just think that this is just a human problem. It's not. And the third is maybe use the G20 platform to form smaller groups of like-minded countries who want to tackle a certain problem and use their expertise to tackle that. Say Australia and India wants to look at Nipah and Hendra viruses. Someone wants to look at obesity with us. We can use their expertise, their technologies, our existing capacities, look at R&D strongly how we can improve research and development, and this could be across science, across technology, across manufacturing, and like Professor Kang very rightly pointing out, it could be R&D in policy and regulatory issues as well, right? How can we get best practices from across the G20 nations, but smaller like-minded groups focused on a particular thematic problem, right? And India could probably provide a framework of how that could work together. I hope that will bring in some resilience, some long-term solutions that we could take forward, and result in a slightly more equitable kind of solution for the G20 countries. I'll stop with those comments.
Thank you,
Sachin.
Dr. Nayak, for that very rapid but also really, very specific points that you brought to the table. Dr. Padam Shetty, over to you. And
Yeah. Yeah. Good morning to all of you. It's 11:50, so we still have time to say good afternoon. I think there's an advantage and disadvantage to sit last in the panel. So either everyone would have spoken everything and you build on it. The disadvantage is you don't have anything to talk about. But I have something to talk about. It's very different in the context because I come from a training. I'm a medical doctor as well as I specialized in foreign policies. So I work in the interface of health and foreign policy. So I look at a issue from a very different perspective here when we talk about issues. From last evening to now, I see 5 C's mainly discussed. One is COVID, climate, carbon, conflict, crisis. It can be health, energy, food. You can group many components in this. And common suggestions which have come, which I have captured, I would have missed, but you can add later. One, if you want to solve this, you need to really solve, because we have spoken a lot about the problems. Let's speak about the solution. It's a mindset. Because there is always a dichotomy in terms of how we look at an issue from a globalist approach and the statist approach. The proponents of pandemic treaty, the countries, if you see, are the countries who practiced statist approach to the maximum. Yeah, so the nationalism. So how do you actually tackle this mindset? We can speak a lot of words saying that there should be cooperation, coordination, collaboration. But what we don't speak is 2 words: compassion and contextualization of the evidence. Because if you see, we need content to make decisions, then it's an evidence-based decision. If there was an evidence that there is an inequity, we should have solved by this now. Why? Why we have not solved? Because evidence is one component of policy making. It's evidence-informed policy making. We really have to look at different dimensions when we want to solve this issue. So when you actually look at certain languages in the treaties are more of monitoring, accountability, lack of compliance. But why don't we talk about something moving from monitoring to mentoring? Not all countries are in the same status. I think we need to build on this. I'll come to my other points a little later. Over to you, Sakshi.
thank you. That was also very rapid, I think. Thank you for sticking to time. So I see some themes emerging from what the panelists have been speaking to. Big theme around regulation. I think that's something that has come up almost in what everyone has said, whether that is regulations for products and regulations for, in a sense, processes, but also regulations for registries. So how do we actually approach data, and how do we look at having social safety net programs which are regulated also well? The second, I hear a lot around capacity, and that's capacity, whether capacities and competencies of people, of health, human resources. You mentioned mentoring. I think there's a lot of scope over there that we can also consider. We spoke about capacities of different countries and how they can actually support in creating whether it's distributed networks of stockpiles, building on where their specific competencies might lie, or also the disease monitoring framework that you mentioned. And then I think there's this big focus on how do we ensure continuity, and not just focus on just a pandemic, not just focus on what the interest of one nation or one particular G20 presidency may lie on. So maybe with that, Dr. Kang and Dr. Desai, would you like to just maybe share a little bit more about learnings that we have or learnings that India can itself glean from other G20 presidencies, past and probably even some of the future presidencies, and how do we bring maybe continuity to this question? And I leave it to you to speak to the question of competencies and capacities of human resources or of regulations.
I can go ahead, please.
So I think what you've hit on for learnings is really important, and it was highlighted that there is a discontinuity between G20 presidencies. So everybody wants to have the one thing that they are known for, and that means that even though there's supposed to be a troika, the activities don't really carry forward in the way that they should. And maybe one of the learnings is that even if we focus on different aspects of one of the C's that was pointed out by Dr. Padan Shetty, which is COVID, and use that as an opportunity for continuity by addressing different aspects that are related to health, that would be useful. Because if you build capacity that is to respond to a pandemic, pandemics don't happen all the time. They're not sustained all the time. Those capacities can be utilized and repurposed for other issues that are really important for public health. When it comes to epidemiology, looking at non-communicable diseases and communicable diseases, some of the tools are very, very similar. So we can think about doing that. Strengthening regulation, as you pointed out, whether that is to do with data or that is to do with products or to do with registries or processes, is something that stands us in good stead in health-related activities throughout the future. What did we learn from previous presidencies? From Italy, I don't really have huge learnings that I can recall. But if I look at what the UK did, some of it good and some of it not great. As with many other countries, in a crisis, you focus on yourself. And that's the right and appropriate thing to do, because you want to look after your families before you go to help your neighbors. Now, what the UK has done is set up systems that have allowed for a lot of interactions within their country, but those systems informed the world. So if we look at many of the policies that have been developed by WHO in the last 2 years, if you dive into the decision making, a lot of the information for those decisions actually came from what the UK was doing for itself, which ranged from looking at infection control in the built environment to doing studies that decided how frequently you should boost. Take a look at the big, bold decision that the UK made to give 1 dose of vaccine to their people while delaying the 2nd dose so that you could expand the number of people who had at least partial protection. Those were actually learnings for the world. So there is a lot that we can learn from previous presidencies. What we should be thinking about now is what do we plan for so that we teach the world what needs to be done for health following our presidency.
When we think in terms of health in G20, there are 2 aspects of it. One is what nation states do within their own boundaries, within their own systems. And second, what do they do jointly and together? And it seems to me that G20 is a forum where we should be focusing on some of the joint activities, perhaps to a greater extent than the individualized activities. So what are the areas where there are opportunities for collaborations and putting in place something for the global good or our joint good? Okay. One area seems to be that I have been surprised at the amount of siloization there has been around research, biomedical research, specifically access to cell lines, human genome data, etc. Countries have fairly strong siloed approaches to what is being allowed to take outside of their own boundaries. Okay? Coming up with some sort of a good framework for the global good, given that now we are more sensitized that disease doesn't have any boundaries. Okay, would be a very useful thing to do. So focusing on somewhere along the line, how do we share scientific research, information, and knowledge, and perhaps needing some regulation around it, but thinking that through. Second area which has also been an issue has been around the authorization of vaccines and medication, because at some level, how much do we share across countries in common in terms of our genome sequencing, and how much is different, and at what extent are we willing to take the trials conducted somewhere else? Again, coming up with some sensible, interesting protocol around that would be a very useful thing. Let me end.
Thank you, Dr. Kang and Dr. Desai. Maybe I come to Dr. Patanchetti and to Dr. Leheria now. So both of you mentioned something very similar in terms of are we looking at international versus global, and are we being statist, or are we being globalist? And so I guess my question to you, and I think Dr. Desai also referred to that, what do we do globally? So how do we approach the question of health from a global perspective, and maybe what is this global health architecture that needs to be in place?
So this issue of international or global has been raised for last few years. Let me give you a specific example that of this monkeypox outbreak, which has become a public health emergency of international concern now. The disease is known for 5 decades. 11 countries in Africa were affected, but nobody paid attention because because it was seen a national issue of those countries. When we say that internationalism in health, it essentially means that every country is looking inward and they are prioritizing their own areas and they are not thinking of others. And that's why approach to health should be global, that no matter whose challenge, where the challenge is occurring, everybody would take care. So if a global health approach would have been followed for monkeypox, the disease was endemic in 11 countries. If a global community was thinking about it, we might not have been the situation which we are now. Even now, the inequities context we are talking because of nationalism. Of course, Dr. Kang also reflected about that. When there is a crisis, every country would look inward, and which is very fair. But when there is no crisis, when we are talking about preparedness and response in the future, that time a global approach has to be followed, that the countries which do not have access to drugs, diagnostics, and vaccines should also be in our thinking process. And so that's a global part. And final point here is that I think inequities, we thought that we have learned something from COVID-19 pandemic and world is better prepared. But even today, when we are talking about inequities, to my understanding, far more smallpox vaccines which can be used in monkeypox or teicoviramate, the therapy which has been approved for monkeypox, it's mostly available in the countries which are being affected now, and it's not available in the African countries which required it for so many decades. So those inequities, the lessons seems very superficial, and that's a challenge with all of us and for G20, and that's what we should be reflecting upon. Thanks.
Thank you. So, again, a different perspective. When you actually think about equity, I think we really need to have to look at the social position of a country, because the differential vulnerability leads to differential susceptibility to a problem, and differential susceptibility lead to differential outcomes. That's what we have seen very clearly in any crisis. So the unique window of opportunity we have as we lead from December G20 presidency is the policy, politics, and the problem statement can come together in this context. So there is a problem which we have discussed in length in last two panels and yesterday. We discussed, and the intellectuals have highlighted what policies can play a role and how politics can influence the outcomes. So what we really have to understand from the solutions perspective is, can we look at innovating incentive systems globally? People who follow the norms should be incentivized, and countries which promote or mentor other countries to reform and have a better facilities. I'm not focusing on one sector or actor. They also need to be incentivized. People who help and also people who follow the norms. So the innovation in incentive system is very important, and that is open for discussion among different stakeholders, because different actors and sectors contribute in terms of thinking. Because if you look at the COVID-19 situation, the WHO was put at the center saying that nothing was done, but the issue was with the compliance. International health regulation, no one complied. So the issue is not with the IHR, issue is with the compliance. Then we spoke about intellectual property rights. So who negotiated it? Doha Declaration, we clearly asked for when there is a public health emergency of international concern, we need to look at the things very differently. But who followed it? No one. So we have WHO, we have WTO, we have World Intellectual Property Organization, and different even institutions can come together and look at revised innovation incentive systems on how we can channelize and reward the people who do innovation, and also help people who don't have innovation, but people who have innovation can look at it. So the four essential functions, if you want to look at global health governance system, and this is a very good article from the Chatham House. They said management of externalities is important. Either you talk about positive externalities or negative externalities. It can be positive production or negative production, or positive consumption or negative consumption, which we see every time. We ratified Framework Convention of Tobacco Control, FCTs. How many countries have ratified? Very few. IHR regulations 2005 keeps ratifying, but no one is following. Now we are talking about pandemic treaty. Do you think it will happen? Unless we change the mindset in terms of looking at differential vulnerability and appreciating the differences, it's difficult. So I stop here.
Thank you, Dr. Patanjali. And Dr. Nayak, maybe I come to you to say, we've spoken about a lot of things. The G20, India takes on the G20 presidency at the end of this year. What would you suggest is the process that we follow to sort of ensure that we're able to get so many of these critical points on the table and really sort of see that continuity, whether it is from the Indonesian presidency to India to Brazil next? How do we see this? How do you see this process really be moving forward?
Thanks, Archie. I think a lot of the process is already in place from what we understood from Mr. Khan's speech. There has already been a study of, I think, previous presidencies and what we can learn from those and how processes can be set forward. I reiterated, I think someone yesterday also said 190 meetings is a lot. So how much we actually glean from there is one question, and how do we actually make that a constructive process to take forward. I think understanding from previous presidencies, understanding our own success, I think we did a lot of good in COVID at a very rapid scale. And I think we can learn from those processes and ensure that there is some consultative stakeholder analysis being done as we move forward. I think a lot of this falls on getting like-minded people to address like-minded problems, shared problems. I think if we can focus on that, then it will be easier for us to put forward ideas that may be actionable.
Thank you. I have a clock, a timer, which is really rapidly running out of time. So maybe I will say 15 seconds down the table. What's the one message that you would want people to take away from this panel?
For all of public health, data and quality matter. If we don't measure it, we won't make a difference. That's one lesson for now and the future.
humility. I think we have been incredibly wrong in so many things that perhaps dealing with data with some humility would be useful.
Being mindful that G20 is a high-level forum, so I would say it is opportunity to strengthen governance architecture for pandemic response in the time ahead. Thanks.
I personally hope that we come out of the COVID shadow and look at health in the perspective of health and not just as a pandemic related thing that we need to focus on.
A computation to cooperation.
Thank you. I think that was really succinct and sharp and clear. I think Janvi is going to be very happy with us for really sticking to time. Thank you so much to the esteemed panelists, but also to the audience. And I'm hoping this is just the start of the conversations. We have a lot more to do as we move forward. Thank you.
Thank you.